Hello and welcome to On the Record. Healthcare officials tell us the curve is flattening, and that means they managed to slow the spread of COVID-19 in our community. It also means that things like restrictions and distancing and sanitizing also appear to be working. As ordinary citizens, though, we have a critical role to play in stopping the spread of COVID-19. This as hundreds of healthcare workers go on the front lines every day to try and keep us safe. In this edition of On the Record, we're going to take you inside some of those institutions where that great work is being done every day.
So the project really pays itself back.
Correct.
They set up
At the conference, more the school.
As a journalist, I always have to focus on the facts, and sometimes that means going to investigate for myself. On the Record, Thursdays at 8 p.m. right here on RTV.
In direct response to the COVID-19 pandemic, the South Beach Clinic was converted into a 10-bed facility capable of treating patients presenting positive. That facility officially opened on April 20th, dedicated specifically to treating patients who presented with mild to moderate symptoms. Patients are seen and treated there every day, just as they would be at the Princess Margaret Hospital.
A triage station is where it all begins. This is where they determine what happens with the patients.
This area is our triage area. This is where we get all of our patients. And we determine from here what is going to happen, what is the final disposition of the patient, whether they're going to be treated and discharged home, or whether they're going to be admitted to the inpatient area, okay? So here we have a host of nurses. This is one of our nurses. She does all of the patient's vitals. She checks their temperature, their oxygen level, but she's being shy. She checks their blood pressure. And then we have a triage sheet where the doctor gets all of the information from the patient, and we determine based on this information and based on the vitals of the nurses on that, what level of presentation the patient is, whether they're mild, moderate, or severe.
Patients are referred by other clinics, the hotline, or are brought by ambulance.
More than likely, this is a person who has been referred to the center from somewhere else, maybe Princess Margaret Hospital, I'm not sure of the details yet, or from the hotline, or from another center like Flamingo Garden Clinic or Elizabeth Estate Clinic. They come in, we assess them, they get admitted on the inside. If you would notice, the ambulance drivers and the ambulance attendant, whoever is in there, they are in full personal protective gear, because these are either confirmed or suspected patients. Ambulance driver hands over to the patient to the nurse. That's the protocol. All patients are the first be handed over to the nurse before they get be seen by a physician. So that's what she's doing right now. She's handing over the patient. More than likely, this patient is going to be admitted. Once they come in the ambulance, that's the most likely patient who fits the criteria for admission. So the triage is going to happen on the inside for this person, where we're going to take a full history. The nurse, Nurse Murphy was telling you earlier today, they bundle everything. So whoever goes into that room with that patient, they're going to take the vitals. They're going to give medications if need be. They're going to put up IV infusion if need be. It might be a doctor. It might be a nurse. More than likely, it's going to be the physician. Okay? And once the patient is admitted, we provide all of the care that we think they need. We don't work in isolation. This is very, very important to note. We never work in isolation. So once the patient is admitted, we are in contact with the physicians at Princess Margaret Hospital, and this is very important, from the internal medicine department and from the infectious disease department. And so once we've given a presumptive diagnosis, we call our colleagues in internal medicine and infectious disease, and we relate that information. There's usually a ward round where that person from internal medicine or infectious disease come from Princess Margaret Hospital and actually sees the patient. Based on their medical assessment, we decide whether that patient should remain in this center or whether they should be discharged. So nobody is discharged without seeking the medical advice from the internal medicine and infectious disease, and they are based at Princess Margaret Hospital.
Should the patient have breathing problems, there is a nebulizer station set up on the outside, just as a precaution.
We can safely nebulize them right here with oxygen, and so if their oxygen level is low, we call that hypoxia. Sometimes when they use the ventilator pump, or what we call the MDI, the metered dose inhaler, it doesn't work. Sometimes they need additional oxygen, and it needs to be high pressure. And so we can nebulize them right here. A lot of people we've nebulized because they went to other clinics. Unfortunately, they don't have the facility to nebulize them. We've nebulized them. They say they feel significantly better. The shortness of breath resolved, their wheezing resolved, and they feel good. So thanks to this good nursing staff here, they provided this for the patients. And so we are very, very proud to say that we are one of the only centers that are still offering this system in the age of COVID. Because sometimes when you nebulize people, you aerosolize some of the viral particles and you put everybody at risk. Because it's on the outside, it's being diluted by natural ventilation, and so that significantly minimizes the risk.
Despite the steady flow of patients showing up, the team here has been able to handle the traffic.
Since this center has been running in, the government has put a lot into this. A lot of work has gone into. We've had a lot of cooperation from the medical staff, from the nursing staff, from different people in the healthcare industry, whether it's from administration, the logistical part of it. We've had a lot of cooperation. And so since we've opened, we've treated and discharged over 50 patients right here in this triage area, and we've admitted almost 20 patients so far. If you know, when you went inside, there's only one patient because most of them have been discharged. Okay? When we got their results, if they've resolved, we discharged them. And so it's dynamic. Sometimes we do swabbing. When we do swab to see if a person has COVID, there's a booth here that we use. This booth has been built and designed by Dr. Williamson Shea, and he has distributed these to some of the places that treat COVID patients. So the healthcare worker would stand behind here, thanks to Dr. Shea, and we would get the swab from whoever our assistant is. Usually it's a nurse. She stands in the distance while we put the swab in the patient's nose, okay? And we collect the sample, all right? And so a booth like this provides total safety because this is plexiglass and there's absolutely no contact with the patient. And when we actually do insert the swab, even if there is aerosolization of the viral particles, the physician is totally protected because he's behind this protective glass. It's very simple. Very simple. It's like a glove. We've swabbed with this. It's, if you notice, the end of this is sort of like serrated, and this one here is smooth. So there's no problem grasping the swab. And if you look, the dexterity is very, very, very normal. And so there's no problem, you know, using like a pincer grasp. to manipulate the swab and then insert it in the patient's nose to get a sample. So this is very, very simple.
These booths were the creation of consultant surgeon Dr. Williamson Shea for the protection of all healthcare workers involved in the testing phase. He says he was inspired by online images.
Essentially what this does is that the person doing the test can be inside the booth and not be affected by any aerosol spray that the patient may produce when you do swab the patient. So behind that plexiglass is sort of, you blocked and protected from any spray. And the person puts his arms through these long gloves here, and it does the swab, and then they can put the swab in the media and then bag it and package it and have it sent off to the laboratory. So and then after that person is being swabbed, then they could spray this down with a disinfectant and go on to the next patient. What that does is saves persons putting on the PPEs, which are one, expensive, and two, it saves PPE for when we need them. So in essence, it serves dual purposes.
He also designed and built an intubation chamber and some other helpful safety equipment.
That essentially helps to intubate patients and again prevent aerosolization of the spray when you intubate it. So, and I also did some hoods for the centrifuges in the lab, as well as what we call a hood for during the surgery. Mm-hmm. But in addition to all of this, I must put a little plug in. We have a lot of volunteers who made these types of masks. They're called mask angels, and they made over 1,300 masks, and we've distributed them throughout the community. Hospital staff, physicians, nurses, patients. So we've done quite a bit.
On the inside of the South Beach Clinic, nurse in charge Tamika Knowles is a part of the team working on incoming patients.
So the process is we have nurses stationed at the gate, so they would be stopped there initially to ensure that they are coming at the right place. All right. So if they are coming through the call center, they would be provided with a case number, and so they would give us that case number, and they proceed to the back, where they are assessed and triaged by our doctors and nurses there. Now, if their symptoms warrant them being admitted, meaning that they're not well enough to self-isolate at home, then they phone in to us on the inside, and they are admitted and managed accordingly.
All other clinic functions are suspended as they focus only on suspected or known positive cases.
A detailed history is obtained, and also the swabbing that is very pivotal in diagnosing this COVID-19 is done as well. From a nursing aspect, depending on what symptoms they present with and the type of management that the physician wants to give would be what we carry out as well. So it's a multidisciplinary approach. We work together to try to get them well. So our policy as nursing and health professionals, our policy is that we treat each other as suspected cases. So everybody and anybody that walks in the door can be possible COVID cases. So it's a lot of care and attention that has to be going into managing these patients. Mm-hmm.
While there is a risk of transmission, she's not at all worried.
I don't, because we have been and we are provided on a daily basis with the proper protective gear, and so we know that we are putting on what is necessary for our safety, and we ensure that everybody is taking the same precautions. So we're doing our best to keep safe. So safety is not an issue for me personally, and I don't think it's a concern of my colleagues here either.
Those concerns are more so for the public that are not always compliant with the rules.
There's always that challenge. There's always that concern. I think this is where education is important, very important, and it has to be something that's constantly reiterated because a lot of things that seem so simple, people are taking for granted. And so we have to constantly encourage the purpose of a mask and the purpose of social distancing. And so that's something that every day you have to be educating. So you will find that people will try to shortchange, they will try to run around.
And still to come in our program tonight.
I spent 22 years of my life at Princess Margaret Hospital, so this comes actually easy to me. You know.
What's the difference in working between the two?
Well, there's not much difference, you know. The same operation, we try to mimic the same thing that they do here, we do here, so we do the same thing. Nothing really different.
Welcome to On the Record.
Looking for more On the Record? If you miss our Thursday showing at 8 p.m., join us for the re-airing on Friday mornings at 10, and then again each Sunday night at 8:30. Or go to our YouTube channel and catch up on all of our past episodes. And then like our Facebook and Instagram pages for a preview of upcoming shows and get a chance to ask your questions. Just look for On the Record.
Under normal circumstances, the South Beach Clinic is one of the more busy facilities within the public healthcare system. But these days, they see strictly suspect or COVID-positive patients. Their operations in many ways mimic those of the Princess Margaret Hospital, with few exceptions. They take walk-ins, referrals, and even the overflow from the main hospital. Having just witnessed a patient arriving by ambulance, we saw firsthand the clinic's medical staff in action.
The patient is handed over to the nursing staff. So the nurse receives the patient and determines which one of the inpatient room that the person will be admitted to. Once that patient is admitted, the nurse does the vitals on that patient. When I say vitals, we try to see whether the patient is clinically stable, so she checks the blood pressure, she checks their oxygen level, she checks their temperature, she checks their respiratory rate. From there, the physician who is assigned to the inside will go and evaluate that patient. He's going to take a full medical history to determine what is going on with that patient, and to the best of his ability, he is going to do a clinical exam so that we can make the most accurate presumptive diagnosis, and from there we could know how we are going to manage the patient. In terms of management, every patient that is admitted, they're going to be swabbed. A nasopharyngeal swab is going to be inserted to see if that patient has COVID, what their COVID status is. We also take off bloods for serologies. When I say serologies, we're going to take off one for the viral studies. We're going to take off to look at their liver. We're going to take off basic chemistries to look at their sugar, to look at their electrolyte levels, and to look at their kidney. We're also going to take something that we call a complete blood count to see whether the person is anemic, to see how high or how low their white blood cells are.
The call then goes to the internal medicine and infection diseases team at PMH to share patient diagnosis.
To let them know that we have an admission, to see what further management is needed if necessary. And usually once we've gotten all of their results, we contact our colleagues again in internal medicine. We share that information with them, and then based on that information, we decide the disposition of the patient, whether they will remain for treatment for a few more days or whether they will be discharged based on, one, their COVID status and whatever their presented complaint is. And so it's a multidisciplinary approach. It's not just us here. We have a lot of assistance from our colleagues at the Princess Margaret Hospital.
With regular COVID patients, safety is job number one here. Like their colleagues at PMH, they too work in a buddy system.
So that means whoever is the person who will be entering the patient care area would have to be properly donned. What we do is we put up a sequence of every step that you must go through. We're not relying on no memory. It's written, take it step by step. And then your buddy will make sure that you put everything on in the proper sequence so that you're fully covered, fully protected. And that is what helps decrease our fear factor. You're totally donned, you're very safe, you're very covered, every aspect of you is covered. so you can go into the area and feel safe to be with the client.
Patient contact is limited, and when that is done, the reverse happens in doffing, potentially the most dangerous part.
What we try to do is bundle the care. Everything that may need to be done for that client, we try to do within that time frame to limit the amount of exposure our staff has to the patient who may potentially be contaminated with the COVID virus. Once you've come out of the patient care area, we go into another specialized room, which is specifically for what we call doffing, which is taking off these equipment. This is the most crucial part of it, because this is the point where most people will get contaminated themselves. So we will also have another poster which goes step by steps. Getting on is only 15 points. Taking off, you'll see that poster probably have close to 30 points. But it's a very meticulous process. It's very time consuming, and you have to do it step by step in order not to contaminate yourself whilst you're taking off these articles that may have been contaminated whilst you are in the room providing care. And the reason we do that too is, aside from shift systems, also we pay special attention to our physicians. And you'd find that a nurse is always with a physician when they are donning and doffing, so that we can make sure that they are also being well protected, because we need them. We all need to be safe. You will come down to either one of the patient's care areas. We have it set up that there is a doffing room between each patient area. So you'll go into the patient room, provide your care to the patient, and then there's another door on the inside that you'll come out to into the doffing area. Once you've come into the doffing area, you'll see that we have a clean side and a dirty side. So we have to make sure that everything dirty stays on the dirty side. Once you've already cleaned and sanitized, then you'll come into the clean side to go into the clean area, which is the corridor. So like I was saying, taking off, 24 points. And it's a lot of hand sanitizing, a lot of hand washing that we have to constantly do. Every single piece of protective equipment that you take off, once you've taken that off, you have to sanitize again. So if we put on 8 pieces of equipment, that's 8 set of sanitizing. Well, that's actually 10 set of sanitizing, because you'll come out, you sanitize, you take off one piece, you sanitize, and you'll go straight to that to the end, and then you sanitize all over again.
This facility also gives another important service: clearance for people needing time off or those who want to return to work.
We've had a number of people who we've already swabbed. They are symptom-free. They need some type of medical evaluation and documentation that they are safe to go back to work.
Moving patients through multiple facilities involving many different healthcare workers can be a challenge, but they've been able to work seamlessly due to the level of cooperation.
They have been, since we've started this operation 3 weeks ago, very, very cooperative. So I really, really want to thank my colleagues at Princess Margaret Hospital, both in accident and emergency, internal medicine, and infectious disease, for always being accessible. We can reach them by cell phone, we could reach them by extension, we could reach them by the general numbers at Princess Margaret Hospital, and there has never been a problem in accessing them. So once we have a patient, we have concerns, we've already examined them, we've already given a presumptive diagnosis, and now we need further, more specialized help. It's very, very, very easy accessing those specialists, and there hasn't been a problem. But you asked the challenge. The only challenge is they're not physically here. But if we need them to come here, there is no problem, because we've never had a problem in the past.
As the patients move in and out of the clinic, they are preparing to more than double their inpatient capacity from 10 to 29 beds, with each room having its own bathroom. Clinic Administrator Elaine Lightford is overseeing the construction as well as the day-to-day operation.
Once the patient room has its own bathroom, you don't have any reason to go into the main corridor, and the nurses can come in here, and you can, as the patient, you can use the bathroom privately. You have dignity and privacy in using the bathrooms, because right now we have commodes, and persons really don't like the commode, so they're putting in the bathroom so you can have some privacy and dignity in your private room. We started the construction here about 2 weeks ago to give us more room space.
And what's going to happen once this is all done? What is this going to look like? What's on that side?
It's going to be the same identical thing as the other side. The other side actually is going to be looking like this because they don't have bathrooms on the other side. So we're going to put bathrooms in the rooms on the opposite side also.
So I have to ask, what is it like working with all this construction going on? You've got patients on one side, and you've got this on the other side.
Well,
What's it like?
it's sometimes get a bit cumbersome, but we work through it every day. Like I call myself the wind beneath their wings because my role here is to make sure I keep them safe as possible. I'm the person responsible for making sure I'm getting the PPEs, getting the rooms clean and tidy, high clean once the patient is discharged, making sure the patient eat, the staff eat on time. That's my job here in this facility as the facility manager.
A veteran in hospital administration, she knows the importance of adhering to the safety protocols.
We have to work as buddy. If you're not safe, then I'm not safe. So we try for everybody to be safe as possible. I spent 22 years of my life at Princess Margaret Hospital, so this comes actually easy to me. You know.
What's the difference in working between the two?
Well, there's not much difference, you know. The same operation, we try to mimic the same thing that they do here, we do here, so we do the same thing. Nothing really different.
For now, the construction is a temporary inconvenience. Once completed, though, they will be able to accommodate more than double the amount of patients.
In 2010, when there was an earthquake in Haiti, the Ministry of Health had determined, based on expert opinion, that there could possibly be a surge of cholera that could happen. And because, you know, we're very close with our Haitian brothers and sisters, they immigrate and emigrate to and from the Bahamas and to Haiti. And so we have always been aware in the Department of Public Health that pandemics do happen. And so from 2010, plans were already being made to turn this facility into a urgent care facility. It's always been on the table. The government has never abandoned it. And you know, we've come through several pandemics. Remember the swine flu, H1N1, Zika, dengue, chikungunya. And so there's always been a constant, ongoing effort to turn this place into a center that will serve and protect the Bahamian people in the event of a pandemic. All of this has been brought to light when COVID came, because COVID is real. And so the government has been very, very, very serious about protecting us, all of us as Bahamians, our friends, our families, and so that is why this center has been turned into what it is right now. What I foresee is that after this crisis is over, and hopefully it'll be over soon, this will always be a center to serve the Bahamian people in times of a pandemic. I'm sure that it will go back to an outpatient facility where we continue to serve Bahamians on an outpatient basis. But in the event that we urgently need a center in case there's a pandemic, this will always be here. If you've noticed, some of the rooms have been converted for inpatient care. They've been turned into bathrooms have been added. I don't know if you've been through some of the rooms. There are oxygen gauges on all of the walls. And so this is not just a primary care center anymore. We can now admit people overnight. If people need to be oxygenated, all of the rooms are equipped for it. If people need IV infusions, we have trained nursing staff and physician staff who can do that. And so I think this is a very good investment, very good foresight by the government to build a center like this, because we never know when we're going to need it again. Hopefully it'll be no time soon. But the Department of Public Health, the Ministry of Health have been very, very robust. They've been very, very aggressive in their efforts to protect the Bahamian people, and that's why this center is here right now.
And coming up inside the National Reference Laboratory.
So We have to be very careful that there is no spillage, because as you know, we have swabs that have viral media.
Hello and welcome to On the Record, and the balanced, true and open debate you've been looking for. From the very beginning, our health officials have relied on the real-time PCR tests to provide the official numbers on COVID-19. Despite calls for the rapid test to be introduced, they held fast, using only the gold standard PCR test to provide official numbers. The National Reference Laboratory is responsible for receiving those samples and providing test results every single day.
So many of us walk past it every day. The National Reference Laboratory is housed in one of the only standing buildings left from the historic Royal Victoria Hotel on Shirley Street. This is where most of the in-country HIV/AIDS testing and analysis is coordinated. But whenever an epidemic of any sort threatens, they must pivot to lead testing. COVID-19 is no different. Dr. Indira Martin is the director of the National Reference Laboratory.
Right now, because all of the COVID testing is manual rather than automated, it's been a great uptick in the work that's happening up here and the amount of manual work. So that's a big component of it. We actually tried to order an automated RNA extractor. So you saw the RNA extraction bit. And we tried to order that, but because of the global short supply of those machines, we haven't been able to get it in as yet, although it's bought and everything. In fact, we've even had an issue with trying to get the manual RNA extraction kits. So that's been interesting. I mean, I spoke to the vendor of these kits, and they said it's been surreal, literally surreal, in terms of the demand versus what the companies are able to make in a good time. So that's been interesting. A lot more time spent here because we've had to do more of a 24-hour kind of shift, whereas we're used to being in more of a 8 to 5 kind of lab. It's allowed us to increase our capacity in terms of instrumentation, and PAHO has been such a wonderful partner in this regard, because when you first came and you saw the freezer to the left in downstairs, that's a donation from PAHO, and that's a very expensive freezer, so we have to be very thankful to PAHO for some of the capacity that has been built during this time with their help, because in the next outbreak, beyond COVID, of course, we'll have this ability now for expanded testing. So I try to look at it in that kind of wider view of having been through a few epidemics. I realize that epidemics they're bad, obviously, but for a lab, it's a time to build as well for the future and to hone and to make your response better, you know, at the lab level. I'm proud also that we were able to respond at our level at the lab to this pandemic, because it came about. I just saw the other day an email from the CMO where she had asked, there'd been a cluster of respiratory cases in Wuhan at this time. This was around January, and she had asked us to try and find a diagnostic. And thanks again to PAHO, and thanks to all the work globally of people in China and Germany who were just rapidly sequencing the viral genome, we were able to, via the network, the global lab network, public health network, we were able to get a donation of these kits. You know, they weren't the CDC kits. I know that was a big thing at first. The CDC kits were faulty, and we actually requested some, but they never came. So we've been using the PAHO WHO kits.
And our international affiliations have helped us to be in a much better position.
Especially when you have a novel virus, and it's not as if we could cook up these ingredients in the Bahamas, you know, because we'd never seen this virus. So having that international network has been so key. Also in terms of like technical dialogue and just being able to compare notes on this novel virus, you know, across the world. I remember when this first came out, being on the phone to Hong Kong, University of Hong Kong, late into the night, you know, trying to get their ingredients, their primers for this virus, because they were obviously very close to the epicenter. And sharing experiences about what they had been through you know, there has been vital, before the virus came here, we were able to say these are some of the issues that have been seen with testing and kind of prepared us, you know. So the information flows very nicely through the network, I find.
The demands of a global pandemic have created a shortage in needed supplies and the ability to get them here as quickly as we would like.
Beginning with the swabs and also the RNA extraction kits has been a really big challenge that we've been unaccustomed to, because usually you just think you order something and you get it, you know. But with this, it's like sometimes it's up to a month that it's taking to actually come into the country. And so it's been kind of nerve-wracking. We never run out, but but you know, it's obviously nerve-wracking when you know that you have to keep testing in order to deal with the epidemic. But thankfully, we just got in a very big order of both swabs and RNA extraction kits, and it looks like it's going to get better going forward.
All right, just going to swab, all right? Excellent. There you go. Just going to press in your nose so you get it the right path, okay? All right, now this is going to be a little bit uncomfortable. And out. Next side. And out. Specimen. All right, so what we want to do is to get at least about 5 to 7 mils of blood for our test, okay?
Specimen now collected and labeled was packaged and sent off to the National Reference Lab for analysis. As swabs are collected, they are brought here. Shanaria Whitfield, a 6-year medical technologist, receives them and begins the process.
When samples come into the lab, they're first brought into the RNA extraction room. So you can follow me. And so this is our rack where we put each sample and we line them up. Then there is a line list in which the patient's name and information is here. And so what we do is that we number up the specimen to match the forms, after which after assigning numbers to the specimens, we then in turn bring them to the fridge, and we'll put the samples in the fridge to keep them cool. And after which then Mr. Tavion would then accept the forms, and then he would accession them in our accessioning room, where he would put them on the computer, name, demographics, age, and the test that is about to be performed on each sample. Accession is assigning a number, so each sample that comes in gets a number that is assigned to the specimen. And it also ensures that when we are testing, that we don't have to have the names on each sample, because they are already supposed to be matching numbers that have for each patient's name and medical records.
Each step is governed by a set of safety protocols.
So we have to be very careful that there is no spillage, because as you know, we have swabs that have viral media. And so when they are sealing the tubes, we have to be very, very careful that in the bag that they come in, that there are no drainage or spillage that can in turn come to us. And so we also ensure that we wear gloves, make sure that we don't handle anything without using gloves. And that also helps us to be protected, as well as wearing our gowns that ensures that there is no spillage on our clothes, etc., etc. So here is a typical container in which the sample arrives to the lab. And so, as you can see, it is well taped and secured. So when we open the package, you can see here that this is a container in which it is properly sealed. If I was to open the container and show you, there is an ice pack that keeps the sample cool, because in transport or transit, you have certain conditions. It could be too hot, and so this ensures that the sample is kept in a cool condition. RNA, which is the COVID virus, is very fragile. Unlike DNA that is double-stranded and is more stable, RNA under certain conditions can degrade, and so it's very important to keep the sample at an optimal temperature, as cool as you can keep it, because like I said, it could degrade under hot temperatures.
The next step involves isolating the components of the virus.
Even before we begin testing, we do a thorough clean down. We use 70% alcohol, and we also use something called RNase. And so what we do is we ensure that if we have any RNA, which is from the sample, that is truly from the sample and not from external factors like the air, because RNase can degrade the virus. So we decontaminate the surface area with RNase to destroy any other RNase. And when we collect our sample, we know that this is actually from the patient and not from contamination. So we ensure that we have a very sterile environment. The first thing that we do after Mr. Tavion has a session, then we'll collect our sample, which should have a number. And so the first thing that we do is we have something called buffer AVL. So what this does is it's a viral lysis buffer that actually opens up the cells that corona might be lodging in. Because we know that corona enters the cells. That's how it works, right? And so we'll add the buffer with about 560 microliters, and we'll add it directly to the sample. After which we have carrier RNA that ensures that we get the yield from the sample. And then afterwards we follow a step, a protocol from the manufacturer. And it's like cooking. It's very simple. We just follow step by step the procedures until we come down to the end of it, where we actually use microcentrifuge tubes. And what this does is that it collects the sample at the bottom. So if you draw your attention to our centrifuge, we have a series of steps where we use the centrifuge, and we'll spin the specimen down. And what the centrifuge does is that it concentrates the virus at the bottom of the tube. So after it's done, then we'll take our extracted clean virus, and then we will take it and when we are finished, we archive all samples in a storage container that is stored at -80 degrees Celsius.
Samples are kept to confirm results.
Because in our lab, as a quality assurance, we do confirmations on all of our positives. So never once do we release a result and just leave it as that. We also go back to the sample to ensure that what we said was actually the case.
Samples are also frozen and kept for future studies.
We freeze the sample. Yeah, so that's kept. It's kept in order to confirm, to repeat and confirm, but it's also kept as like a library or an archive for later usage, and in particular, we're looking at hopefully doing some work like genetic sequencing work.
Research.
Yeah. So we'll be able to look hopefully at the genetic sequence of what strain came here, how many times it entered, and that kind of stuff.
As lab technicians, they come face to face with deadly viruses all the time. COVID-19, while a novel coronavirus, was not new in terms of handling infectious diseases.
Well, working in the lab for about 6 years, we were taught that we should treat any sample as infectious. So you never let down your guard, irrespective of what the sample is. And we trust our PPEs that these are designed to keep us well protected. And as long as we have these on, we should be fine. But of course, with a novel virus as corona, you're not sure exactly how the virus behaves. And so, of course, there is a certain element, where you might be a little fearful, but you still trust your training and what you have to keep you protected.
The next step in getting the results involves the actual testing of the extracted sample.
This box should basically be free of all organisms, of all contaminants pretty much that might harm our test. And that's why, I don't know if you hear, but there's a special airflow happening in there. And it uses a HEPA and a UV filter to basically clean the air that's in there and recirculate it as clean air. So that's just another way of keeping it nice and clean. And in here we would normally get out a cold box, which is in the freezer, but I won't get out right now. And then on ice, we need to prepare our ingredients for the PCR reaction before we add the RNA to it. And in the ingredients, as I said, would be those gene-specific primers that will go and look for actually the E gene in the SARS-CoV-2 virus. And if it's there in your RNA, then that means that you have an acute COVID infection, in that the RNA has been found in the present time in your sample. If you do not have it if it's not detected in the final PCR, then that means that at this time you do not have in that sample, at least, this virus.
This lab only uses approved PCR tests, found to be the most reliable when testing.
There would be a little bit of an incubation period. They think it's about 10 days to 2 weeks. And after that, I might get some symptoms, I might not. But if I have symptoms, starting on day 1, the PCR is able to detect from that point, from day 1 to about day 10 of symptoms is the most sensitive period for PCR. Thereafter, eventually, obviously, you're initially positive, you have RNA in your sample, but obviously it resolves over time. Usually we're finding the resolution takes about, they say 2 weeks, 2 to 3 weeks to resolve if you were initially positive. And thereafter, you will have antibodies potentially to COVID-19, but you would no longer be PCR positive. So I think it's important to, recognize that there's a specific time period within which the viral RNA is actually present in the infection.
Important to note is the time frame when the virus is transmissible.
The person is most transmissible during their time of highest viremia, which would be during this acute phase. So once it's resolved, there's no more passing on of the virus, because there's no viral RNA, there's no virus in the system to shed. So basically the PCR test describes the time during which the virus is transmissible.
Once the test is complete, they can now determine a positive from a negative.
You have your RNA, your patient RNA, and you have the master mix ingredient with the primer that's looking for the particular gene for COVID. And when you mix all that together, if the person was positive, they'll have, if you could think at the molecular level, they'd have like a lot of viral RNA in their RNA extract. And when you add the master mix ingredients to that, they look for the little bits of COVID RNA in the extract. And what they do is, because of the way that it's configured, the master mix is configured, what it does is it finds those little bits of genetic material from COVID, and then it causes for a reaction that leads to the amplification of the amount of genetic material for COVID. And during this time, there's an emission of fluorescence because the ingredients have a fluorescent tag to them, pretty much. So as you get more and more, as you see, it's like an exponential rise. You start off with a little bit of RNA, 1 becomes 2, 2 becomes 4, 4 becomes 16, and so on and so on and so on. And this is an exponential rise in RNA or particles that is depicted here in this curve. So we run it for 40 cycles, and if after 40 cycles we don't see an amplification curve, then we say this person is not detected. If we do see an amplification curve, we know that the reason why it's amplified is because there was some RNA in that initial sample that was COVID-19 specific. And therefore, there's been an exponential rise or amplification in that genetic material.
In all, this could take up to 24 hours, longer if they get very large numbers.
It takes long, actually, to even the extraction that was just described. That takes about 2 hours if you're doing a rack of, say, 24. And then the PCR itself, you have to set it up, and then the PCR itself is just over 2 hours. And then you got to analyze, you got a result, you have to perform equality checks, you have to confirm any positives. So that's why we usually ask for the grace period of 24 hours, at least 24 hours. If we're overloaded, it can go up to 48 hours. Like, obviously, the other day we had a whole lot of people come in at once. So when that happens, you know, it can be up to 48 hours.
And each day all results are sent to the surveillance unit and the chief medical officer.
How many tests were done the previous day, previous 24 hours, how many positives, how many negatives, and how many are pending. And I also send a line list to surveillance, to the head of surveillance, and they do their analysis, and they also do their contact tracing and so on. But there's another stream where we have a lot of hospitalized patients, so we have to send results back. So a printed report is sent back to the hospitalized physicians.
Ahead in our final segment, a UWI student comes home to escape the pandemic and ends up on the front lines.
I came thinking that, oh, COVID's this big bad disease, and like I thought everyone there had been like so strict, I guess. But since I've been there, I must say it's been a very nurturing environment. Like, I've had very good experiences learning how to deal with diseases and stuff like that when it comes to analyzing and being safe and cautious and stuff like that. Also, they've teaching me how you're supposed to act in the lab when it comes to working with others as well. So it's been a very good experiences I've had.
Matt, where in the world is Matt Lauer? Where in the world is Alison Greenslade? And so it's about the low value of contingent in Atlanta. So we can talk about it.
On the record tonight, the government's purchase of the Grand Lukine is a hot subject in the news.
The National Reference Laboratory is always pivotal in any ongoing battle with an infectious disease. It's the one place where officials are sure to get the raw data they need in dealing with a situation like COVID-19.
Most days, lab supervisor Keith McConnell and team here are involved in the ongoing HIV/AIDS cases. COVID-19 has added a heavier testing caseload and meant a new risk for HIV/AIDS patients.
This allowed some of the testing we can't do right now because we can't do the full volume, because we usually have a lot of patients come in, so we can't really do the full volume. The people with HIV are much more susceptible because it is a comorbidity that people have to deal with, and since they are immunocompromised, they do have suffer that problem. So their level of self-quarantine should be very high.
Operationally, the lab has changed, but not to the extent we would have thought.
We always have a state of hyper-awareness when it comes to safety. I mean, HIV and we actually do with dengue and some of the other diseases that are out there, we actually process those too. So we're not doing really much anything different. We're always constantly hyper-aware of where we are, where our hands are. This is how we work. So it hasn't changed in that way from a laboratory point of view, but it has changed from the perception of other people. So,
when you say perception, people think, are they a little more sensitive to you now because they know that you're in here and dealing with this?
yeah, exactly.
Sensitive is putting it nicely.
Yeah.
3 months ago, Tavion Smith was preparing to graduate from the University of the West Indies in Barbados with a degree in biochemistry. These days, he's working at the lab here and completing his degree online in the evenings.
Well, when COVID started breaking out, Beam started leaving the campus, moving droves, and then after a while, my family's like, the next plane you get, you better come home now. So,
having made the decision to return home, he was encouraged to volunteer.
And my father said, you're learning these skills. He said, I think the Prime Minister talked on the news about needing volunteers and stuff like that. So he's like, demonstrate your skills, help out. So when I talked to a nurse who's a check on me when I came in from Barbados, and I talked to her about it, and then next thing I knew, I was talking to Dr. Martin. Now I'm here, and it's been a ride.
In the fall, he hopes to do a master's in bioengineering and to return to this lab that's given him an opportunity of a lifetime.
I came thinking that, COVID's this big bad disease, and I thought everyone there had been so strict, I guess. But since I've been there, I must say it's been a very nurturing environment. I've had very good experiences learning how to deal with diseases and stuff like that when it comes to analyzing and being safe and cautious and stuff like that. Also, they've teaching me how you're supposed to act in the lab when it comes to working with others as well. So it's been very good experiences I've been at.
And like so many others, he's proud to serve on the front lines in the COVID-19 fight.
Especially seeing these hardworking individuals, I'm very proud because Dr. Martin especially, no days off. I've seen her, she's been in countlessly, working very hard. She even been teaching me the skills, her and Dr. Whitfield even some call too. I must say, it makes me very proud to be here.
The work being conducted at this laboratory is so crucial. Before any serious measures can begin to treat COVID-positive patients, the process must start here with the diagnosis. Dr. Martin believes that as a country, we are making significant progress, and with more supplies, we will be able to reach even more at-risk groups.
Because right now we've been focusing more from a surveillance public health epidemiology perspective, which has been working, I think, to be honest, because we're looking for the cases, we're looking for the contacts, testing the contacts, testing their contacts, and that's been kind of working because now we're seeing quietening down generally. We test pretty much blind, to be honest, so we don't even know who's connected to who. We just have a name and a sample, really. But after the fact, because I attend meetings, I'm able to see how the dots kind of connect. So the trends that we're able to be are really trying to relay right now, and I think there'll be more analysis later, but what we're trying to relay right now is basically just the basic information, which is just positive and negative and so on. But that line list that we develop goes to surveillance, and they do all of that work with the analysis.
Well, that's going to do it for our program tonight. A very special thank you to the folks at the South Beach Clinic as well as the National Reference Laboratory. We continue to salute all of our frontline healthcare workers and the awesome job that they continue to do. On behalf of my production and technical team, thank you so much for watching. Until next time, I'm Jerome Sawyer. We'll see you right here on The Lab.